Hi, we'll discuss the questions of surgery asked in this CBT exam. Okay, there are 30 questions. Let's see. The first question of surgery. 44-year-old, gravida 3, para 2 female, mother was diagnosed with breast cancer at 65, comes to see you in the clinic after being told that her more recent screening mammography was read as Biarritz 3, probably benign. How do you counsel her? Okay, so Biarritz score you will get when you do a mammography. Okay, it extends from Biarritz 0, 1, 2, 3, 4, 5 and 6. 6 is already biopsy proven. 4 and 5, 4 is probably malignant, 5 is highly suspicious of malignancy. Highly suspicious of cancer, this is probably cancer, 3 is probably benign, 2 is benign, 1 is negative when you don't find any abnormality, and 0 is, you can say, non-diagnostic and insufficient exposure. So in case of non-diagnostic, you repeat either mammography or you go for some other investigation. In these cases, repeat mammography after 1 year. In probably benign, repeat mammography after 6 months. In 4 and 5, you need to go for a tissue diagnosis, most likely core needle biopsy. And in this case, already you have tissue diagnosis, so you can go for the treatment straight away. Okay, so this is probably benign Biarritz 3, so you will tell the patient to come back to see you in 6 months with repeat mammography. Next question. Following a motor vehicle accident, a 35-year-old male, and there is right-sided renal injury and he is unstable. So renal trauma, unstable, you have to operate the patient. Despite IV fluid and massive transfusion, the patient is still unstable. The decision is to take him to the OT. What incision should you use? So remember, in a trauma, if you are opening up the abdomen, no matter whether it is renal injury or liver injury or the spleen injury, the incision should always be midline vertical, extending from the xiphisternum to the pubic symphysis. Okay, always midline vertical incision for trauma. Okay, if the abdomen is opened in trauma, it will be opened by this midline vertical incision. Okay, so this is flank incision can be used in case of renal surgeries, like elective renal surgery. Suppose you want to do nephrectomy or some pyelolithotomy, then in those cases you can go. Chevron incision is a bilateral subcostal incision, usually for the pancreatic surgeries or the hepatobiliary surgery. This is chevron incision. Subcostal incision is, right subcostal incision is used for usually cholecystectomy. Left subcostal incision can be used for splenectomy. So answer here is midline vertical. Which among the following angle numbered is known as azimuth angle? Okay, so when we do a laparoscopic surgery, this angle between the instrument and the surface, this is elevation angle. This should be ideally 60 degree. So suppose this is the port which is showing the camera. This is the telescope. And these two are the working instruments. Okay, so the angle between the camera and the working port, this is azimuth angle. And that should be 30 degree ideally. And one more angle, the angle between two working ports. Okay, this angle. This is the manipulation angle. Manipulation angle, that should also be around 60 degree. Okay, so these are the angles which is very important while doing laparoscopic surgery. So if you have, if your ergonomics is good, then the fatigue and the difficulty during the surgery will be less. So that's why these are the angles. So this was 2. 2 is the azimuth angle. Gain in length at 60 degree angle in the procedure shown in the image performed. So this is the image which is showing Z-plasty. In Z-plasty, we'll have two triangular flaps, like suppose this is one flap and this is the other triangular flap. So when we do a Z-plasty, one thing you need to remember is when you elevate these, suppose two triangular flaps, the angle in a standard Z-plasty is 60 degree. So standard Z-plasty angle is 60 degree, and the new length of the scar you will get is 75% gain in length. There are different types of Z-plasty, but the standard Z-plasty is 60 degree and you'll get 75% gain in length. In 30 degree, you will get around 25% gain in length. There is 45 degree also, around 50%. There is 90 degree also, where you will get approximately 120% gain in length. Okay, so this is Z-plasty. Standard angle is 60 degree and the standard gain in length in 60 degree Z-plasty is 75%. Which of the following statement is true regarding subclavian steal syndrome? So in the subclavian steal syndrome, suppose this is the subclavian artery, this is the vertebral artery going on both the side. This is subclavian and it goes as axillary artery in the limb. We all know these vertebral arteries joins and forms basilar artery, which goes and in this circle of Willis, which is the circulation in the brain. So the main problem in the subclavian steal syndrome is there is occlusion in the first part of subclavian artery. First part occlusion. So because of this, there is less blood going in this axillary artery and vertebral artery. Now suppose patient does some heavy work with that side of arm. So because of heavy work, there is increased demand of the blood. So that increased demand is fulfilled by reversal of flow in the same side vertebral artery. Normally the blood is going towards the brain, but now to fulfill that increased demand, there is reversal of flow in the ipsilateral vertebral artery, that is option number A. So when this thing happens, the blood supply to the brain decreases and the patient can have symptoms like giddiness or visual disturbances. Okay, so this is subclavian steal syndrome. The treatment is most of the time you can do PTA with stenting. Percutaneous transluminal angioplasty with stenting is the treatment for subclavian steal syndrome. Which among the following is not a criteria for damage control surgery? See, damage control surgery you will do in those cases when the patient comes with massive abdominal trauma with hypothermia, coagulopathy, and acidosis. Okay, these three things are known as trauma triad of death. So hypothermia, pH, coagulopathy, blood pressure is not a criteria for going into damage control surgery. Okay, so hypothermia like temperature either less than 35 degrees centigrade or less than 93 degrees Fahrenheit. Coagulopathy, prothrombin time more than 60 seconds or partial thromboplastin more than 60, this is 16. Or if the INR is more than 1.5, acidosis like pH less than 7.2 or the base deficit is less than -8. So in these cases, in damage control surgery, basically what we do is instead of doing the definitive surgery in the first go, we will just do the life-saving intervention. Okay, like we'll control the bleeding, we'll control the contamination, and then we'll send the patient to phase 2. In phase 2, the patient will go to ICU and they will do correction of this trauma triad, these three things. And in phase 3, that is definitive surgery, we'll take the patient again into OT, usually in 48 hours. And this time we will do the definitive surgery and we'll close the abdominal wall. Okay, so this is damage control surgery. Good recovery in head injury according to Glasgow outcome score. Remember, Glasgow outcome score and the Glasgow coma score are not same. Glasgow outcome score is seen after you manage a head injury patient, how well the patient has come out from that injury. 5 is when there is good recovery. Good recovery means patient comes back normally and usually he can do whatever work he was doing before the injury, he is able to do that. 4 is moderate disability. Moderate disability means patient can take care of himself, but he is not as functional as he was before. There is some disabilities present, but he can do his day-to-day work and he can take care of himself. 3 is severe disability. So in this case, patient is dependent on someone. In this case, patient is independent. In this patient is dependent on someone for regular feeding or changing of clothes or going to washroom. He is dependent on somebody. 2 is when there is persistent vegetative state, means the patient is in coma. And 1 is when the patient dies. There is nothing like 6. So in this case, good recovery is A, that is 5. Okay. Next question we'll see. A 40-year-old male who went for skiing fell from a cliff and was trapped under snow for significant time, and he was later rescued, and a large clear vesicle formation is seen along with hyperemia and edema, partial thickness skin necrosis. First, what degree of frostbite it is? In the first degree, there is just hyperemia or edema. In second degree, there is partial thickness skin loss, and usually you will see a clear vesicle formation. Clear vesicle means a vesicle which contains clear fluid. In third, there is full thickness skin loss and usually a vesicle which contains blood, hemorrhagic vesicle formation. And fourth is when it goes more deep, if it goes up to muscle or bone. Frostbite usually can go deep because of the ice crystal formation in the tissue. The injuries are usually deeper. Okay, so answer here is B, that is second degree. Which of the following is true regarding the salivary gland tumor? Parotid tumors are most likely to be malignant. This is false. Parotid is 80% of the time they are benign. And submandibular, 50% of the time they are malignant. Okay, in this 20% malignant. Parotid are mostly benign. Submandibular is equally malignant and benign. Submandibular gland tumors are more likely to be malignant than minor salivary gland. This is also wrong. In the minor salivary gland, 90% are malignant. 90% are malignant. Pleomorphic adenoma may undergo malignant degeneration. That is correct. In 3 to 9% of the cases, malignancy may be seen in pleomorphic adenoma. The longer the pleomorphic adenoma is there, the higher are the chances of malignant transformation. Okay, suppose pleomorphic adenoma is there for 5 years. The risk of malignancy is less than 1%. Suppose it is there for 15 years, 20 years, then the risk of malignancy is as high as 9%, 10%. Warthin's tumor is benign. Okay, it is benign and the risk of malignant transformation is almost always not seen. So the only true statement in this is option number C, pleomorphic adenoma may undergo malignant degeneration. Femoral hernia in NIHAS classification. NIHAS classification is a classification of hernia where class 1 is indirect inguinal hernia with snug or tight deep inguinal ring. Okay, the deep inguinal ring is fine, it is tight. In 2, it is indirect inguinal hernia with dilated deep inguinal ring. 3 is posterior wall defect. In this 3A is direct inguinal hernia. B is direct inguinal hernia along with indirect inguinal hernia. Okay, this is also known as pantaloon hernia. And C is femoral hernia. That is our answer. And there is one more, NIHAS 4, that is recurrent hernia. Okay, if once you have done the treatment, again it has occurred, that is 4, that is recurrent hernia. Next question 11. 22-year-old young male and present with left inguinal hernia. During examination, hernia is identified, but also there is a testicular mass. Testicular mass in case of adults is malignancy until proven otherwise. Most 99% of the testicular mass will be cancer. Okay, if it is cystic swelling, then it is most likely hydrocele, but a solid mass in the testis is cancer. Painless, firm, patient had not noticed it previously. What is the primary landing zone of the retroperitoneal metastasis in a left side testicular germ cell tumor? They are asking if it is a tumor, then lymphatic drainage is going where? Okay, so suppose this is the right testis and this is the left testis, and suppose this is IVC and this is aorta. So testis, embryologically we all know it develops in the abdomen, in the retroperitoneal area, then it descends down. So that's why the lymphatic drainage goes to near the IVC and aorta. These are known as retroperitoneal lymph nodes. So the right-sided lymphatic drainage goes to the paracaval or interaortocaval lymph nodes. Paracaval or interaortocaval lymph nodes. And the left-sided goes to pre and para-aortic lymph nodes. Pre or para-aortic lymph nodes. Okay, so here the patient is having left testicular mass, so it will go in para-aortic lymph nodes. That is the same kind of lymphatic drainage you will see in kidneys also. In kidney also same kind of lymphatic drainage is seen. Next question, patient emergency severe epigastric pain, lipase is also raised, which is diagnostic of acute pancreatitis, but patient described multiple episodes of pain in the past and enzyme elevation since childhood, and he was put on conservative treatment. CT reveals calcification. Two relatives with similar pain attack. So calcification in the pancreas, you should go with chronic pancreatitis. And here there is a history since childhood and relatives are also there. So it is most likely hereditary chronic pancreatitis. So they are asking which of the following gene mutation is most likely to be associated with the, in this case. Okay, so hereditary pancreatitis, there are genes which are responsible. The most important is PRSS1. Second is SPINK1. Third is CFTR. Okay, these are the main. There is one more CASR, but the most important is PRSS1. BRCA1 is not associated with chronic pancreatitis. So hereditary pancreatitis, most common gene mutation PRSS1. Next question, alcoholic male history of recurrent pancreatitis, CT was done, which reveals calcification. So again it is chronic pancreatitis and a dilated main pancreatic duct of 11 mm. There is no evidence of mass or any other thing. So what is the best long-term management? So if the main pancreatic duct diameter is more than 7 mm, then in these cases we can say those surgeries in which you can say there are two types of surgeries we do for chronic pancreatitis. One is resectional procedure, okay, in which you will resect the head of pancreas, but if the duct is dilated, then you do drainage procedure. Okay, so if it is like this, then you will do drainage surgery. And the drainage surgery in these option is LPJ, lateral pancreaticojejunostomy, that is Pistos, and there is one dual surgery, that is only the tail part you will remove and do the anastomosis. In LPJ, suppose this is the pancreas and this is the duct. So first you will open the duct longitudinally. If there is any stone or anything, you will remove it. Then you will bring a loop of the jejunum and anastomose it side to side with the jejunum in a Roux and Y fashion. So this is a longitudinal pancreaticojejunostomy. So this is the answer for question number 13. Going to question number 14, 35-year-old trauma patient, malabsorption, requires nutritional support. All these things, actually the question is that the patient needs total parenteral nutrition. And which of the following is most appropriate site? So when we give total parenteral nutrition, usually the bag or the solution in which we are giving through the vein, that is hyperosmolar solution, like more than 1500, 1600 up to 2000 milliosmolar. So that is hyperosmolar. If you give that with the peripheral veins, then it will cause thrombophlebitis and it can cause damage of the vein. So that's why we have to give this TPN through the central veins. Okay, we'll give through the central veins. Common veins are like subclavian vein, internal jugular vein, and femoral vein. Now, among these, femoral, you can see it is present in the groin and there is increased risk of infection. So that's why this is not the preferred site. The preferred site is subclavian. Okay, so subclavian vein, central venous catheter you will put for giving TPN. Regarding the given figure, which one of the following statement is incorrect? Okay, you can see this is a keloid. Okay, so fibroblasts have increased sensitivity to TGF-beta1. That is true statement. Both in keloid and hypertrophic scar, if you see, there is increased expression of TGF-beta1, both in keloid and hypertrophic scar. Tension during closure is a contributory factor. Yes, if there is tension between the tissues when you do the suturing, it can lead to keloid as well as hypertrophic scar, both. Scar parallel to the underlying muscle may prevent this condition. So if your incision is parallel to these, you can say these are known as Langer lines or the relaxed skin lines. So if you give incision parallel to this, your scar will be much better. If you give perpendicular, the scar will be poor. Infection is a common cause of this condition. That is the false statement. Infection does not cause keloid. Okay, so infection is not a cause for keloid formation. Treatment of keloid, we all know you will give intralesional steroid. Intralesional steroid is the first line treatment. After intralesional steroid, you have other options also. You can give 5-fluorouracil, imiquimod, silicone dressings are there. You can use surgery also, but if you do only surgery, then recurrence will definitely occur and that recurrence will be worse than the initial keloid. So that's why if you're planning surgery, you have to add after surgery either silicone gel or silicone sheet or intralesional steroid or some chemotherapeutic agents like bleomycin, etoposide can also be used. Okay, so remember, only surgery is going to worsen the condition in case of keloid. A 5-year-old girl arrives and nausea, vomiting, abdominal pain. She has no significant past, but mother gives history that she was involved in an accident about a month ago. So 1 month back she had some road traffic accident and she was sitting in the car and there was a seat belt she had applied and there is blunt trauma to the abdomen. At that time she had no problem. Vitals were also fine and she was subsequently discharged after initial evaluation. BP is, this time also BP is okay, pulse is not bad and respiratory rate is high. It is high. Chest X-ray is shown. So you can see in this chest X-ray, this side is looking normal. On this side, this part is lung and then you can see these shadows present on this side. So this is basically a traumatic diaphragm injury, which is more common on the right side. More common on the left side. And remember, in traumatic diaphragmatic injury, initially patient will not have any significant complaints because just the bowel has gone into this part. So initially people, they focus on the life-threatening injuries and many times this diaphragmatic injury gets missed. And later on, like in this case, the patient has presented after 1 month with complaints of this respiratory problem and abdominal pain. So no matter when it is diagnosed, whether it is diagnosed 1 month later or 2 months later, but you have to do surgery. There is no management in treatment. So this is diaphragmatic hernia. Treatment is surgical repair. Either you can primary repair or if the injury is big, then you have to put a mesh also. The best investigation is diagnostic laparoscopy. Diagnostic laparoscopy, put a laparoscope and see where is the injury inside. When should parenteral antibiotic be given perioperatively? Parenteral antibiotic is basically antibiotic prophylaxis. Antibiotic prophylaxis, which we give in most of the cases of elective surgeries, we give antibiotic prophylaxis. Okay, be it abdominal surgeries, mostly we give for abdominal surgery. For the clean wounds like breast and thyroid and salivary gland also, many people they give antibiotic prophylaxis. So this should usually be given, you can say 30 to 60 minutes before the incision. 60 minutes is better. But suppose you get a option which is at the time of induction of anesthesia. At the time of induction of anesthesia, then that is a better answer, because usually this is practically what we follow. When the patient is on the OT table, you give this antibiotic to the anesthetist, and usually they will give at the time of induction. Okay, antibiotic prophylaxis can be given as per the procedure you are performing, but most of the time it is a second generation cephalosporin. And one more thing you remember. Okay, so this answer is 60 minutes prior to the incision. The part preparation. Part preparation is while doing the surgery, when you remove this hair from that operative area. So remember, it should only be done if it is absolutely required. If you feel that the amount of hair is going to interfere with your surgery significantly, then you do the part preparation. And the best way of doing part preparation is not shaving, not depilating cream, it is hair clippers. Hair clippers, or you can say the trimmer. And this should be done not a day before surgery, not the night before surgery. This should be done in the OT before shifting to the OT table. Okay, in OT before shifting on table for surgery. Just before you shift the patient on the main OT table, that time you do the part preparation with the hair clippers, if at all it is necessary. If it is not necessary, it's not a ritual that any patient who is planned for surgery, you go and remove the hair. Next question, 65-year-old female, microscopic hematuria and cystoscopy shows a low-grade TA bladder tumor. What is the appropriate treatment? See, in the bladder cancer, TIS is in situ cancer, TA is low-grade papillary cancer. Okay, it is superficial only. T1 is if it involves the lamina propria. Lamina propria is the mucosa. Okay, T2 is when it involves muscle. T3 is when it involves the perivesical fat, that is the fat around the bladder. And T4 is when it involves the adjacent structure. So these tumors are known as non-invasive tumor. And these are invasive tumor, that is muscle invasive tumor. So in invasive tumor, first you will give neoadjuvant chemotherapy, and then you will go for surgery. In this surgery, you will remove the whole bladder, radical cystectomy. And after removing the whole bladder, you will create a new bladder using the intestinal loops, ileal loop. But in case of non-invasive, instead of removing the whole bladder, you will do a cystoscopy, and through the cystoscopy, you will just remove the tumor by making small cuts, and you will remove the whole tumor. So that is known as transurethral resection of bladder tumor, TURBT. And after TURBT, because you have not removed the bladder, so there are chances that it might cause recurrence. So after that, to prevent the recurrence, you can give intravesical either chemotherapy or immunotherapy. Immunotherapy is usually given for high-grade tumors like T1 or TIS. For a low-grade papillary tumor, a chemotherapy is enough, and one of the common chemotherapeutic drug is mitomycin. So the answer for this is TURBT followed by intravesical mitomycin. Next question, 5-week-old boy, and there is vomiting, and there is vomiting. Between vomiting, patient feeds vigorously, and at this time the patient is having, these are the features of severe hypovolemia. Because of the vomiting and unable to eat, the child is hypovolemic. See, the presentation is 5 weeks. This goes very classically in the favor of IHBS. Infantile hypertrophic pyloric stenosis. In this case, this condition, which was previously believed to be congenital, now it is considered it is not congenital, it is acquired, and seen in kids, mostly in the male child, usually after 4 weeks of birth. So this is not seen at the time of birth. This develops usually 4 to 6 weeks later, and the presentation is very classical, non-bilious vomiting. Okay, 4 weeks later, acquired condition, non-bilious vomiting, and you can see a lump in the epigastric region, a olive-shaped lump, and you can see left to right peristalsis, visible peristalsis. Okay, in classical electrolyte abnormality, you will see hypokalemic, hypochloremic, metabolic alkalosis with paradoxical aciduria. Okay, ultrasound is the investigation of choice, which will show you the thickened pyloric sphincter. The treatment, remember, in these cases, when the child has come, the child is having severe dehydration. So first you will do fluid resuscitation. First you do fluid resuscitation, correct the electrolytes, all these hyponatremia, hypokalemia, and after that you will go for surgery. In this surgery, basically you will do Ramstedt pyloromyotomy. Okay, so that is the name of surgery, Ramstedt pyloromyotomy. Remember, these situations when the child, or not only child, when somebody comes with a condition which is a threat to the life, like in this case severe hypovolemia. So before going for any investigation or any definitive treatment, first you correct the basic thing. Suppose somebody comes with severe respiratory distress, then give oxygen first before getting the X-ray or before getting the ultrasound. Okay, somebody comes with somewhere bleeding. Okay, so give blood. Okay, somebody comes with dehydration, give fluid, and then you will try to find out what is that reason which is causing this bleeding or this hypovolemia or this respiratory distress, and then you go and treat that particular thing. Okay, so if they ask what is the definitive step, they have asked the next step. So next step is resuscitation. Suppose they ask what is the best or the definitive step in the management, then the answer would have been surgical intervention, because that is pyloromyotomy you have to do in those cases. Next question, this is hazy vision, small rubber-like nodules, cataract, and during the cataract surgery the blood pressure increased from 110 to 200. PCO2 is normal and his pH is also normal, temperature is high. Esmolol is given, which increase the BP more. ECG shows T-wave inversion. What is the most likely underlying etiology? See, all these symptoms goes in favor of pheochromocytoma. Okay, so which was undiagnosed, and during the induction of anesthesia the BP increased, and that is how the patient presents. And this pheochromocytoma, this small rubber-like nodules and the cataract, these are seen in neurofibromatosis 1. And pheochromocytoma is commonly associated with this syndrome. Okay, so this is intra-abdominal tumor. This is a pheochromocytoma which mostly arises from adrenal gland. Okay, so these questions, some of these questions are quite tough, so you might be thinking why these questions are given to us for the FMGE exam, but believe me, few of these questions you will, like these questions you will see in your exam, and see, when we are preparing, we should prepare for the, the worst case scenario. So this is for your, practice. I had put deliberately these questions so that you get this habit of reading these long questions and trying to get the hints from these long questions and use that hint in order to come to a diagnosis. Okay, in malignant hyperthermia, usually you will see PaCO2 will be high. Okay, in thyrotoxicosis, there is no history as such which is going towards the thyrotoxicosis. Inadequate anesthetic agent will not cause these problems. Okay, so A is the answer. 17-year-old boy, emergency, 3 hours history of pain in the testis. There is no trauma, but he is doing some kind of physical activity, and examination is not very useful because he's having severe pain and he's not allowing you to touch. However, the right testicle does appear to be swollen, slightly tender, slightly red and extremely tender. So this kind of event is going in favor of torsion testis. Okay, the age group, there is some aggravating factor like long distance running, pain, tenderness. So this is torsion testis, and what you do in torsion testis, you have to do the surgery within 6 hours, otherwise that testis will become gangrenous. So instead of doing any ultrasound or urologist or analgesia, shift the patient to OT for emergency surgery. In the OT, you will explore that testis, and if it is gangrenous, you have to take it out. If it is not gangrenous, you have to do detorsion and fix that side with the scrotal wall. And the other side fixation, that is the contralateral orchidopexy, you also have to do, otherwise the next side or the normal side testis will also go into torsion in the near future, and that can be catastrophic. Next question, 3 centimeter painless mass and slowly enlarging. There is firm moves up and down, means it is arising from the thyroid. He denies weight loss, weight gain, heat intolerance. So there is no feature of hypo or hyperthyroidism. TSH is also normal. The most important step in the workup. So this is a solitary thyroid nodule and the patient is not hyperthyroid. So the best thing you can do in these cases is get an FNAC. FNAC is the investigation of choice for solitary thyroid nodule. Put a needle, and after that you will come to know whether it is benign or whether it is malignant or suspicious of malignancy, and accordingly you will do the further management. Which of the following is true regarding the laparoscopic hernia repair? It is generally less expensive. The cost is more in laparoscopic. Potential complications are similar or less severe to those seen with open repair. The complication, although is not very common, but if it occurs, it is more severe. Okay, it can cause injury to the different nerves, injury to the vessels. So complications are not less severe. Procedure is limited to the repair of only one defect in the inguinal region. In this case, when you do the surgery, you will have a very broad image, and when you do the repair, when you put the mesh in these cases like TAPP or TP surgery, you are actually closing the potential sites for indirect hernia, direct hernia, as well as femoral hernia. Okay, so this is also wrong. It is usually favored approach in the special situations such as recurrent or bilateral inguinal hernia. That is true. In case of recurrent hernia, suppose once the surgery has been done from the anterior side or the open side, next time you go from the posterior approach like the laparoscopic approach, so that you enter in a field which is not touched, and it is very nicely cover all the three areas, and with the same incision you can see both the sides. So that's why for bilateral hernias, for recurrent hernias, as well as in females, it is a better treatment option than open hernia. Okay, TAPP and TP are the types of laparoscopic hernia repair. A man presents to the emergency, left loin pain, radiating, and BPH, recurrent UTI. IV shows tandem column on the left, means there is a staghorn calculus. Which of the following type of stone has caused this symptom? See, which type of stone seen in infected urine? What is the type of stone seen in staghorn calculus? It is triple phosphate, that is calcium, magnesium, ammonium phosphate. Triple phosphate, which is also known as Struwite stone. Next question, A female, there was mammography, was unremarkable. There is strong family history, 2 aunts with breast cancer and 35-year-old niece was diagnosed with breast cancer. She does not have any problem. The patient requests counseling on various genetic syndrome. So this question is about which is the correct match. BRCA1 is present on chromosome 17. So this is wrong. BRCA1 chromosome 17 increased risk of female and ovarian breast cancer. This is very true statement. BRCA2 is present on chromosome 13. And male breast cancer is true, it increases the risk of male breast cancer, but it is not present on chromosome 17, it is present on 13. Li-Fraumeni syndrome, chromosome 10, the mutation is P53. PTN gene, chromosome 10, the name of syndrome is Cowden. There is increased breast nervous system is okay, but not GI cancers. Usually it will cause breast cancer, then it can lead to thyroid malignancies, it can lead to PTN mutation can lead to hematomas, polyps in the GIT. But so among all these, option number B is the best answer. Which of the following statements are true in ulcerative colitis? In 95% of the cases, disease starts in the rectum and spreads proximally. That is correct statement. Rectum is almost always involved, and it goes proximally without leaving any area. So there is no skip lesion, there is contiguous involvement. It can involve the whole colon also. In 20 to 30% cases, it might involve the ileum, then it is known as backwash ileitis. Granulomas are mostly seen in Crohn's disease, not in this. Diffuse disease affecting all the layers of large bowel, this is also Crohn's disease. This involves only mucosa or maybe submucosa, not all the layers. Involvement of ileum and jejunum is frequent, like jejunum is never involved, ileum can be involved in like 30% of the cases. So the correct answer here is A. Which of the following statement is not true? The current favored technique for bowel anastomosis is single layer extramucosal interrupted. That is very true statement. The bowel must be prepared prior to any anastomosis. That is wrong. Preparation is required for mostly for, you can say, the left sided colon or rectal surgeries. You don't need for small bowel, you don't need for the right sided colon, you don't need any bowel preparation. By preparation we mean we give laxative to the patient, we give certain oral antibiotic. So the next day when we do the OT, when we open out the bowel, left sided colon and rectum, these are those areas where stool is present, and 50% of the stool is made up of bacteria. So you do not want to work in a area which is contaminated with bacteria. So that's why in these cases, one day before surgery, you will give laxatives, you can give enema at the night also, and oral antibiotics to clean the GITs, so that you will not face the stool or the bacteria. But for small bowel, for the right sided colon, you don't need any preparation, you can straight away go with the surgery. It is essential that in end-to-end anastomosis, the bowel end should match the diameter. That is true. When you are doing end-to-end anastomosis, the end should match, and if they are not matching, then the smaller side bowel, you can make a small cut which is known as cheatal slit in order to match it. So this is true. In vascular anastomosis, polypropylene or proline is the ideal suture. Yes, that is true. Non-absorbable monofilament suture. So that is also true. The only false statement is B. Which of the following are indications for radioiodine treatment? Graves' disease, the first line treatment is antithyroid drug, and if it is relapsed or recurrence, then the second line treatment is this only. So that is true statement. Young children, you don't give radioiodine treatment. I mean, it is a relative contraindication because they have so much life left, and giving radiation in very early life theoretically increases the possibility of radiation-induced cancer later on. Multinodular goiter is not recommended. Multinodular goiter is euthyroid. If it is a toxic multinodular goiter, then it has role. But a simple multinodular goiter is euthyroid. You don't need any radioiodine ablation. Severe ophthalmopathy, if you give radioiodine treatment, it increases, it might increase the ophthalmopathy. Same goes with the arrhythmias. If there is arrhythmias, it can increase the arrhythmias. So that's why in these cases, it is better avoided. A is the correct answer. If Veris needle is used during the laparoscopic surgery for creating the pneumoperitoneum, or you can say carboperitoneum, unintentionally placed in the iliac vessel. So while putting the Veris needle, it is usually a blind procedure. You don't see what is inside. You just make a small nick and put the needle. Usually you hear 2 clicks when it pierces the fascia and the peritoneum. Usually a safe technique, but sometimes, especially in those cases where the abdominal surgery has been done in the past, there are lots of adhesion, and if the new somebody who is new to the procedure they are doing, there are chances that this needle might go into some bowel or some vessel. Most common vessel in which it enters is the iliac vessel. So this is a question that when you are putting Veris needle, initially it has gone in the vessel. You aspirated the Veris needle and the blood comes. Now they are asking what you are supposed to do. So Veris needle is, in these cases, you let the needle be there, you enter in the abdomen using some other sites, and you put the port, you put the camera. Now under vision you remove this needle to see where the injury has occurred, and you just put some local pressure with the laparoscopic instrument, and most of the time that injury is controlled. Okay, so you don't have to worry much about these Veris induced vascular injury. But suppose after you put Veris, when you put carbon dioxide, now the abdomen is distended. Now you are putting port, okay, laparoscopic cannula. So while putting port, that is much bigger. If vessel injury occurs, then in those cases, let the port be there, immediately open up the patient, because the injury occurs with the port trocar is much bigger and it is much severe. In those cases, do not continue with the laparoscopic surgery, immediately open up the patient and prepare for the vascular repair. Okay, so leave the Veris needle in place, proceed with insufflation of the abdomen at a different location. That is the correct answer. Okay. Leave the port and open the abdomen, that is for the port injury. Okay, option number C, instead of Veris needle, suppose it is port, and that is the correct answer. The last question, 55-year-old, previously healthy, post-op day, hemicolectomy, slow to regain mobility, and you want to do DVT prophylaxis, deep vein thrombosis prophylaxis. Enoxaparin is low molecular weight heparin, that is the best treatment option. Okay, you start before surgery, you continue in the post-op period till the patient is ready enough to go home and the patient is sufficiently mobile. Sequential compression devices can be used. It will allow the blood to go back into the body. Suppose the patient is not able to walk or the patient is not conscious, you can put these, we call it as DVT pump also in the lower limb. It will help the flow of the blood and it will prevent stasis. Warfarin may be used, these are the oral drugs. After the initial few days of low molecular weight heparin, you can give warfarin also. But clopidogrel, that is antiplatelet, it is not used in the prevention of deep vein thrombosis. Okay, so which is clopidogrel is mostly used for the arterial diseases, thrombus formation. Okay, so thank you very much. These were the questions of surgery in CBT. I know the paper was a bit difficult. In the exam, you will find much easier question. This is for your practice and to more than practice. This is, I wanted you to read these long clinical based questions, and you should not be scared of these questions. These are easier questions and usually much scoring questions. Thank you very much and best of luck for exam.